Hello, I'm Michael Morris. I'm the section head of prostate cancer at Memorial Sloan Kettering Cancer Center. I'm a medical oncologist, and we're here on Geo-Oncology Now at the Euramigos conference. And I'm here with some good friends and colleagues to talk about radiopharmaceuticals and the state of play as it stands now. Tanya, we'll do some introductions. You're next.
Hi, I'm Tanya Dorff from City of Hope.
I'm Evan Yu. I'm at the University of Washington Fred Hutch Cancer Center. I'm a general urinary medical oncologist there.
And I'm Rana McKay. I'm a GU medical oncologist at the University of California in San Diego.
Very good. So I'm excited here to talk today because we're just come out from a meeting at ESMO in which some new phase 3 data have suggested a potential expansion of the use of radiopharmaceuticals in prostate cancer. But before we drill down to those data, you know, this drug has been around and approved for the better part of the last year. There have been some issues in terms of access of the drug. I think the larger community is now just getting used to using it because now it's actually available. So let's talk a little bit about how you do patient selection, treatment, follow-up on your existing patients currently receiving lutetium PSMA. Tanya, let's start with you. First, how did you manage during the period in which the drug wasn't available? And now that it is, how are you finding its availability, and also which patients are you using it on at this time?
Yeah, those were challenging times. We had a wait list. I'm sure some of you did as well. And best we could. It was first come, first serve on the list, but also who really was the most urgently in need. It's very nice not to have those issues anymore. So now when someone is referred to our center and is eligible, we're able to secure the dose fairly quickly and get them started within a week or two. So we're really sticking to on-label right now, which is post-taxane chemotherapy. And our nuclear medicine colleagues are checking the scans. So even if it's an external PSMA PET, they're reviewing it to make sure they feel that it meets the vision criteria. And just making sure they have adequate bone marrow reserve and those sort of checks. But it's a pretty streamlined process at this point.
I think you raise a really good point in that you need to coordinate with nuclear medicine. Not every institution or practice has that available to them. Evan, how does your institution deal with that need for collaboration? Was that in place existing, or is this something you've had to build from the ground up now that this therapy is available?
We're fortunate in the fact that we have wonderful nuclear medicine doctors that are very engaged. We've been collaborating both for clinical work and for research for years. So it was already in place, and we knew all this was coming, PSMA PET and PSMA targeted radioligand therapies. So we were fortunate that we were able to work together and collaborate closely together to do this, to negotiate those challenging times, form wait lists, determine priority, et cetera. I'll just add that, yes, I think the access challenges have decreased, but just the rise in demand for PSMA PET, that actually has become the rate limiting step now.
Interesting.
It's the fact that our center, it can be up to a 1 to 2 month wait sometimes for PSMA PET because so many people are ordering PSMA PET. Sometimes providers that aren't even from our center are ordering it and they're getting them done at our center. So it's, the challenges shift. Is probably only a 2-week wait now to get lutetium PSMA 617, but the wait to get PSMA PET is actually longer, and we're working through those issues.
Now, moving from the physician and practitioner problems to the patient issues, many of these patients now that we're working through have very advanced disease because they've been waiting for several months. So, Rana, how do you do your patient selection? Who do you decide is an appropriate candidate? Do you use strict count levels, or do you adapt your criteria to the performance status of the patient? How do you approach working your way through that backlog and deciding who's an appropriate candidate now and who's not?
Yeah, very good question, because I think it comes up a lot because many of our patients are more heavily pretreated now in the later line.
there's a lot of finesse that happens with patient selection for patients that are receiving lutetium PSMA 617. And I think when we apply the clinical trial data into the real world, I think there's a certain level of adaptability that we need to sort of think about when giving patients this life-prolonging therapy. So looking at their blood counts, ensuring one that you've optimized all parameters to enhance their blood counts, looking for reasons that they may be anemic or may have a low platelet count or low white blood cell count. But I think integration with our nursing team where we're checking their CBCs, at least 7 days beforehand, transfusing if needed, and kind of actually working with our nuclear medicine team, because sometimes even the dose can be adjusted if somebody does have some lower counts and maybe more heavily pretreated. So there's a lot of adjustments that we can do to actually ensure that patients do get this life-prolonging therapy.
I think that's one of the most actually rewarding aspects of the multidisciplinary care that's needed for these patients is learning each other's perspectives and appreciating each other's skill sets. I think the count issue is one of those domains because you need to sit down with the nuclear medicine folks, look at the PSMA scan, and determine whether someone with low counts has low counts because of tumor burden that may be very avidly PSMA expressing on the PET, in which case you wouldn't want to dose reduce because that could be cleared and they can get maybe worse before they get better, but they will get better. Or whether their counts are low on the basis of prior treatment and radiation exposure, in which case a dose reduction would be appropriate. And having that dialogue, looking at the scan and making those decisions together, it can be really an expansion of everyone's knowledge base. But I do think that the nursing component is really important. We haven't discussed that. And the nuclear pharmacy as well as radiation safety need to be part of that multidisciplinary team, as well as the physical resources, which you've brought up as well. So it's actually a treatment that I think requires a fair amount of both human resources and physical resources. Not every place is equipped or has the financial or resources to do that. So I think those are challenges that the field really does need to meet.